What's the most common case that you usually see?
I see a lot of mummy makeovers. So these are mostly Kenyan women who have an amazing life. They sacrificed often 10 years of their life to raise the children. And then they're looking into the mirror and they say, listen, I don't feel like I look. I want to have my body back.
How does that look like?
It's a daily phenomenon that patients come in and they say, listen, I now want everything. So my aim is always to get my patients as fit as possible. I know it's very difficult if you have breasts that weigh 10 kilos.
Yeah.
So whatever surgery we do, we cannot do it on somebody who's massively overweight. In some patients, I say, you know what, we can do a breast lift, tummy tuck, and we can add some fat in your hip dips. In other patients, I would say it's not possible to do everything at once because this will stretch the surgery time beyond 3.5 to 4 hours. So I never perform surgeries longer than 4 hours.
Before we get to that, BBL, KBL, how did that come about?
A Brazilian butt lift is something that originated from the early 60s, I think. Ivo Pitangui is a famous Brazilian plastic surgeon who started addressing patients' saggy buttocks. The biggest difference is that the Brazilians, they lack the posterior curvature. Now, Kenyan women clearly have that. What they don't have is the hips.
How would you determine, let's say in a Kenyan woman now, who needs an implant and who needs just fat transfer?
I highly recommend not to have an implant into your buttocks. Breast is okay, but buttocks, I never do it and I don't recommend it. I always use fat grafting.
I saw studies and Google that doing fat transfer surgery is one of the riskiest procedures to ever exist.
Undergoing liposuction is dangerous. Doing the fat grafting into the buttocks is the next step of dangerous.
Mm-hmm.
It's highly dangerous.
Is there a BBL smell or a KBL smell?
I've never heard of that.
Welcome, ladies and gentlemen. This is season 3 of the Laughing Lab Coat podcasts. On this episode, we are honored, truly honored, to be hosting Dr. Tilman Stash, who is an internationally recognized plastic and cosmetic surgeon with a wealth of experience. Today's conversation is going to be about cosmetic surgery, specifically where we'll be looking at the Brazilian butt lift, but he has an interesting name for it called the Kenyan Butt Lift. We're going to get into it. Now, what I need you guys to do is, of course, do the subscription, like, comment. If you're really interested in learning about the behind the scenes of how the Brazilian butt lift is done, or stroke the Kenyan butt lift now, stay tuned for this. Daktari, welcome.
Thank you.
How's the journey been? How was Christmas? How was the New Year's?
It was a well-needed break, I have to say. Yes. Spent some time back in Germany. Mm-hmm. Had some white Christmas, which was amazing. Mm-hmm. And then, of course, the Kenyan coast. Doing some kite surfing. It was amazing. It was amazing. Fantastic, yes.
Before we started, you mentioned football. Have you had enough time to do that?
I've started again to play football now because obviously over those holidays, you just eat well and you don't exercise so much. So yeah.
If you were to liken yourself to a football player, who do you say you play like?
Oh God, no! I play number 7, and if you ask me, then CR7 over Messi, definitely. Although both are gifted.
CR7 only. And we wanted to get into the conversation.
Sure.
That's about the Brazilian butt lift. It's a very trendy thing on social media. Mm-hmm. But before we really get into that, I wanted to know a little bit behind why you went into plastics and cosmetic surgery.
Okay. And
what is the key thing that actually tailored you into going this side?
Great. I mean, how long do you have? if I tell you my whole story. Yeah. So I was originally born in Germany. Mm-hmm. Then I completed school in Namibia, mm-hmm. and that got me onto the continent. So I studied medicine in Cape Town, mm-hmm. and then went back to Namibia for my internship. So that was 10 years of Africa experience there, mm-hmm. and that kind of was ingrained or engraved into my heart and mind that this is a place where I might want to be one day. So I went to the UK after that, after my studies, to enroll in the surgical specialities. So I did, you have to do a a mix of specialties before you choose your main specialty. So I always knew I wanted to do plastics, and I'll tell you in a minute why. So I did cardiothoracic surgery, general surgery, colorectal surgery, vascular surgery, emergency medicine, and then gained my membership of the Royal College of Surgeons of Edinburgh, which then allowed me to pursue my specialist wish of plastic surgery. And I started in Edinburgh for a couple of years, then Norwich, and then I completed my specialization back in Germany. I think that was 2008, when I became a Facharzt, or a specialist in plastic, reconstructive, aesthetic, and hand surgery.
In hand surgery, is it like combined all together?
Yeah, this is so I'm talking about 6 years of medical school, 4 to 5 years of general surgical specialties, and another 6 years of becoming a plastic surgeon. So in that specialization, you pretty much work in the hospitals. You see not much of aesthetic surgery. Maybe if something has gone wrong from some private doctors who you have to then fix. So that has happened a few times, where we needed to sort out a hematoma in a breast reduction, or a tummy tuck that had issues. But generally, you rotate through the general plastic surgery, which is burns, a very, very important part of plastic surgery. Most people don't know that. Then wounds, chronic pressure sores, and then basically everything to do with the soft tissues,
Soft tissues, yeah.
If you have an accident and you lose half of your leg, then the orthopedics, they put the bones together, and the plastic surgeons cover the bones and cover the muscles and replace the muscles as well.
Yeah.
And that is really what I found most challenging, the wide range of amazing indications or diagnoses that we have in plastic surgery, and also the technical skills you need. The decision making, so each patient is different, each patient is a new challenge, but then you build on your experience. I learned from the top professors in Germany and the UK, and from their knowledge I have gained so much, and I'm trying to give that back to other younger doctors as well now. But the one thing about what got me into plastics was when I was a medical student, I heard about this microsurgery course.
Microsurgery.
So microsurgery is basically when you not only put on loupes, so these kind of glasses with magnification, but you actually use a big operating microscope, and you stitch together blood vessels, veins, arteries, nerves. And it's beautiful. It's a different world, and that's really what got me into plastics and my interest.
Interesting. When you look back at your early years in surgery, was there like a specific case that you handled and you're like, this is the main reason why I'm going into this side? One specific patient, maybe?
Well, I think it's difficult. I think it's the grind in the hospital when you actually see patients, and it's kind of, I wouldn't say it's repetitive, but it's a lot of the operations that become routine. What I found most stunning is burn patients who are close to death's doorstep, and you basically treat them in an intensive care unit. You place new skin onto their wounds, and you see them walking into your outpatient clinic 6 months later as fully human beings. So that has left a mark on me. Now, I'm not in burn surgery now, I'm in aesthetic surgery, but I still do a lot of plastic and reconstructive work. And so I want to maintain that kind of side of my specialist field.
What was the inspiration behind starting your practice in Kenya?
Oh, so having lived in Africa for 10 years and then back in Europe is good, is great. I loved Germany. I loved working there. But I started coming to Kenya in 2010. That was the first time I came. And that was basically presented one of my research papers at the International Conference of Pan-African plastic surgeons, and that's where I got to know some of the doctors here, and we struck up a relationship with the junior doctors, the senior doctors, and that's how I started coming here, doing workshops, teaching students, teaching other doctors the skills I had gained from Europe, and obviously learning a lot also how things are being done here in Kenya. And over the years, it started to, patients started to ask me, can you fix my eyes? Can you do this? Can you do that? So from 2012, I had a practicing license. And ever since then, I've started building the practice in Riverside. So 14 Riverside, that's where my clinic is. And it's been a fantastic journey since, with lots of ups and downs, but amazing patients. And we've now built a team of 16. And we're doing the whole range of aesthetic surgery, reconstructive surgery, not in the clinic, but in hospitals. We have a dermatologist. We have a Medi-Spa where we do laser treatments, facials, lymph drainage. So basically trying to offer everything under one roof.
That's amazing. And when you're starting up the practice, was there like, because I know I'm Kenyan, I know the challenges of being in Kenya. What was the biggest one you came across?
Well, I had a lot of support from the doctors here who wanted me to open my practice here, and just maintaining that quality and working with in the system. That was the biggest challenge, really, to renew my license every year, and
falling back, coming to be integrated into the system, basically.
Yeah, I mean, the system in Kenya vets doctors to come and practice here. So having been vetted once successfully because of my experience and my qualifications that are international standard and that have been obviously accepted here in Kenya, I had to renew my license every year, which was fantastic. And it always was without a problem. But it was always my wish to become Kenyan. So 3 years ago, I think I got the citizenship, and now I have one license, and I don't have to get the renewal every year.
That's amazing. And moving on to now having started your practice, let's say, what's the most common case that you usually see?
So in the surgery space, I see a lot of mummy makeovers. So these are mostly Kenyan women who have an amazing life. They have had their babies. They have had they sacrificed often 10 years of their life to raise the children. And then they're looking into the mirror and they say, listen, I don't feel like I look. I want to have my body back. And helping and assisting those patients to really regain confidence is what gets me up every morning, and what I love about my job. Because these are women who might feel they want to fall in love again with themselves. And so, what is the mummy makeover? It's addressing things like the tummy. It's addressing things like breasts that might be too large from breastfeeding, too droopy, too small. And then basically body contouring, taking away fat deposits from one area, putting it elsewhere, for example, the buttocks. And just kind of, I would say it's almost like reconstructive surgery. It's getting back to normal.
Okay.
Yeah.
Wow. So now let's say you have a specific patient who comes for the mummy makeover. Talk us through the aspect from the, let's say, breast reduction to, let's say, the tummy tuck to now doing the buttocks augmentation.
Sure.
How does that look like?
It's a daily phenomenon that patients come in and they say, listen, I've read on your website, I've kind of done my research, I now want everything.
Everything all at once.
And then it becomes my task to educate my patients and tell them, look, I'm assessing you. I'm taking a good history examination, and I find that your BMI, your body mass index, might be still a bit too high to safely do all of these surgeries at once. So my aim is always to get my patients as fit as possible. maybe they can lose as much weight as they can. I know it's very difficult if you have breasts that weigh 10 kilos.
Yeah.
If you have a belly that kind of obstructs your running, then I understand that it's very, very difficult. But it has to be safe. It has to be safe. So whatever surgery we do, we cannot do it on somebody who's massively overweight.
Okay.
And there we have different measures of helping the patient to lose. However, not everybody is in that category. So those who come in where I say, this is great, you are the perfect candidate. Now let's discuss which area we need to address first. In some patients, I say, you know what, we can do a breast lift, tummy tuck, and we can add some fat in your hip dips. In other patients, I would say it's not possible to do everything at once, because this will stretch the surgery time beyond 3.5 to 4 hours. So I never perform surgeries longer than 4 hours, because I know as a standard it increases complication rates. It has poorer outcomes, and this is cosmetic surgery, and you do not want to risk the patient's lives or more, or health. So then in those cases, I would say, okay, listen, we can do X, Y, Z in the first operation, and then second stage, we tackle those issues.
So you have to how do you categorize, apart from the weight index coming in? Is there another factor per se that would make you tell a patient or have this conversation with the patient and tell them, okay, let's do this half on this operating day, and then give you some time to recover from it, and then do this? Is there any other factor apart from weight?
I think cost comes in, of course. So for me, the most important thing is the safety. So if I know this operation will take X, for instance, tummy tuck can take 1.5 hours, breast reductions 2 hours or longer, depending on the size. Liposuction can be between 1 hour and 2 hours, and then fat grafting. So I add the components of the surgeries, and then I kind of in my head I know already this one we can't do in one go. And then I ask the patient, listen, what is your biggest concern? Is it, do you need a breast reduction? Do you need a tummy tuck? What is the biggest concern that you want to change? And then it's a discussion.
Okay. Fully understood. Now, let's get into the back scene or behind the scenes of designing someone's BBL. Before we get to that, BBL, KBL, how did that come about?
Okay, so I think so a Brazilian butt lift is something that originated from the early 60s, I think. Ivo Pitangui is a famous Brazilian plastic surgeon who started addressing patients' saggy bottoms. So he came up with different versions of what we now know as a butt lift, Kenyan butt lift. Brazilian butt lift, of course. See, it's deeply ingrained in my mind. So he, as the Brazilian, obviously started doing that. So then the techniques evolved over time. And the biggest difference I see is that the Brazilians, they lack the posterior curvature. So they want to have the augmentation at the back. So we call it the anterior posterior dimensions. Now, Kenyan women clearly have that. I think most patients that come into my office, they have that curvature from the back, and then getting the posterior extension of the buttocks. So, but what they don't have is the hips. Now, the Brazilians don't necessarily want to have the hips. They want the sporty, tight, firm buttock. Versus in Kenya, it's more kind of the hip dips that needs to be addressed, the snatched waistline, so having a nice S-shaped silhouette, the flat tummy, and also the lateral hips. So in Kenya, really, the beauty standards, or in Africa, are quite different from anywhere else in the world. Maybe Southern America, they also like the wider waist to hip ratio. But certainly if you talk about a BBL in America or Europe, those expectations of result are
bit
quite
different.
different. Yeah.
And moving into the technique, how would you, let's say that the Brazilian butt lift is done this way, and now this is how you do the KBL,
Yeah.
the Kenyan butt lift?
So Brazilian butt lift can be done with either fat grafting, silicone implants, or what we call the hybrid augmentation, so composite silicone plus fat grafting. And most of the time, if the silicone implants, they go posterior. So you have an incision in the midline between your buttock cheeks, and then you insert the implant there. So that I never do. So I don't find it safe, and I don't find it practical, and it's not what my patients want. So as I explained before, the anterior posterior kind of dimension is already there. So the main difference is that the Kenyan butt lift is the fat grafting on the hip tips. And of course, sometimes adding fat to the posterior part of the buttocks, for example, if there's dimples, if there's some loose tissue, if there are scars, so then that area is addressed as well.
Yeah. And in terms of like determine, let's say, how would you determine in let's say in a Kenyan woman now, who needs an implant and who needs just fat transfer?
I highly recommend not to have an implant into your buttocks. Breast is okay, but buttocks, I never do it, and I don't recommend it. So I always use fat grafting. And if you ask me what is the biggest challenge that patients need to know about, then it's the 2 to 3 stage approach to the butt lift. So see, you have different shapes and sizes.
True.
You have somebody who has a very small buttock, or somebody who has a very large buttock, but the hip tips. Somebody has a square buttock, somebody has a round buttock. And so everybody is different, number one.
Yeah.
Number two, I can only transplant so much fat for it to be safe. So if I see you in my clinic and I say, listen, it's safer to do it in 2 stages because I cannot introduce so much fat in order to make this dimple disappear and actually give you a curvature, then that is an anatomical factor, because fat grafting means I transfer living tissue, living fat cells into a space that needs to grow its own blood supply. So if I put too much fat in, then the blood supply cannot happen. The fat cells die, and you get fat necrosis, you get lumps and bumps, you get cysts, and so on and so forth. So that is the most difficult truth to convey to patients, that there's a limit to what I can do.
I saw on studies and Google that doing fat transfer surgery is one of the riskiest procedures to ever exist.
Yeah. So
how do we go about that?
Yeah. So I think the most important information for patients out there is undergoing liposuction. Number one is dangerous, and then doing the fat grafting into the buttocks is the next step of dangerous. It's highly dangerous, and it should only be performed by board-certified plastic surgeons who've had the experience, who went through the training, who maybe went for hospitation somewhere with a doctor who taught them, and somebody who has the experience of safely doing it. So liposuction, people think any doctor can do it, but it's a highly specialized operation because there's so many danger zones. So imagine you have a 3 to 4 millimeter cannula, a stick that you certainly insert into different parts of the body. There's the heart, there's the liver, there's the lungs, there's the intestines. There's all kinds of organs that can be
very close to the cannula.
If you're not careful or if you're not experienced. So that's the first bit. So doing lipo properly is very, very important. Using the right technique is important, because if you use a technique that makes the fat cells die, for instance, then you have
It's a waste of
lipo
basically,
harvest,
yeah.
and then the fat that you then introduce is dead cells, and then you just obviously can't get the results. And then the fat grafting itself. In 2019, the Florida Board of Medicine put a rule out that mandates that fat can only be transferred in the subcutaneous tissue. So it cannot be put into the gluteal muscles.
Okay.
And secondly, it has to be performed under ultrasound guided, ultrasound guidance, because during the surgery it's very difficult to feel where's the subcutaneous tissue and where's the fat. Where's the muscle.
Yeah.
So using an ultrasound probe by the surgeon to know which level the surgeon is in order to put the fat
To place,
is
okay.
now an international rule. So ISAPS, the International Society for Plastic Aesthetic Surgeons, has adopted this and recommends this to all surgeons performing this. Now, the reason why this mandate came out was that they had several deaths in Miami and Florida
Yeah.
due to unqualified doctors performing BBL and having deaths due to placement of fat into the gluteal tissue, so into the muscles, which in turn can cause an embolism of fat going into the blood
Major
vessels.
arteries, yeah.
And the buttocks have a lot of big veins.
Yeah.
So the veins go directly to the lungs, through the heart to the lungs, and there patients die because the fat cannot
Including
be
the-
dissolved,
yeah.
including the lungs. So it is a dangerous procedure unless you have a qualified surgeon adhering to all
Yeah.
the safety protocols.
We are walking through case or patient B. We've had this discussion, the intra procedure or intra op. We've already done majority of the work, and now we're getting into the recovery period. How does that look like between immediately post operatively moving into the recovery period? What's the process like?
Right. So I think the process of the operation starts beforehand. So during the consultation, I think we discussed that, and then giving the patient all the information needed, including the complications that can happen, including what to expect afterwards. So that's the question you're asking now.
Yeah.
Then preparing the patient for the surgery. So we always do ultrasound scan of the tummy to make sure there's no hernias or any other abnormalities. We do a blood test in order to see that the blood is
lines are
okay,
okay,
and
yeah.
so on. The patient has to be healthy. During the surgery, standard safety protocols, and doing it in a licensed center. No shortcuts. So you can't have it in an operating theater that is not fully equipped. You need a hospital with intensive care. You need a hospital with the nurses that can look after patients and so on, with a qualified anesthetist. So all of these things have to be in place in order to, first of all,
Have the patient there.
have the patient there, operate safely, and then care after the patient. So now in the ward, so during the surgery, we put a garment on, so a compression garment in the areas that where the fat was harvested. Then normally we turn the patient on the tummy because you don't want any pressure on the transplanted fat. And then my patients stay one night and then they go home. I encourage them to walk, to hydrate, so drink lots of fluids, and we give them enough painkillers for them to be comfortable. We give them prophylactic antibiotics and also to wear DVT stockings so you don't get a blood clot in your leg. They then come back to see me at the clinic on a very regular basis. So they can enjoy their day at home. And then the next day, usually they come to see me. And then we'll do a full dressing change, which means all the dressings are taken off. We clean the wounds. We put new dressings on. We change the garment.
So we were discussing about the recovery period, changing of the dressing, and more. You could elaborate on what the process looks like?
Right. So the regular follow-up, I think, is super important so that the patient feels taken care of. So we do the dressing changes. We then change the garment so that they can wash the one garment and then get the new one. And then after 4 or 5 days, we start the lymph drainage. And lymph drainage, really, there's also a misconception that lymph drainage means we squeeze all the fluid out and it squirts into onto the floor. So that's some videos on YouTube. But the lymph drainage really is, so after 24 hours, there's no more leakage of fluid, number one. Number two, the lymph drainage is really to reduce any swelling. So any injury on your body, so if you hit your knee, then it swells up.
Yeah.
So lymph drainage basically just means it's gently massaging the tissues for the fluid to go into the lymph vessels, and then the patients can pee it out. So that's to reduce the swelling. So that's part of the recovery process. And then basically also managing patients' expectations.
Yeah.
Because a lot of time, day one after surgery, they look in the mirror and say, "Oh my goodness, this is not what I wanted."
Yeah.
And then it has to be on my amazing nursing staff, my lymph drainage specialist, and of course me, to tell them, "Look, this is early days.
Yeah.
Let's look at the final results at 6 weeks."
Yeah.
Because there's swelling, there is maybe bruising, there is fat that still gets reabsorbed. So the final results are only after 6 weeks to 3 months.
Well, what's the most common thing, or rather the overlooked aspect when it comes to the recovery period that would actually put patients back?
Thank God I'd never had to take a patient back to theater for any emergencies for the butt lift. Because I'm conservative and I'm safe. Certain aspects that patients might neglect is nutrition, number one. So having small snacks during the day, multiple energy, carbohydrates, foods high in energy is important to actually feed the fat cells.
Yeah.
So if you starve yourself during the recovery period, then more fat cells get digested by your own body. So that's important. What else is important? Okay, so people always say, I've got this amazing BBL cushion that I'm going to sit on and so on. And then I say, listen, don't waste your money on these cushions, because those American BBL cushions, they're like a donut, okay? So now imagine you sit in a donut. Yes, maybe the posterior buttock will not be under pressure, but exactly where I put the fat, the hips
will be under pressure.
You'll sit on your hips.
Yeah.
So we recommend measures that support your thighs. So if you really need to sit, you can have this. We have a KBL cushion. That is basically just fancy foam that you put under your upper thighs, so that when you sit at the edge of the chair, and then you sit and your whole buttock is in the air.
Okay.
So that works. So
that
keeping
means
the pressure off.
you're basically sitting using your thighs.
Yeah, exactly.
Okay.
So it's not very comfortable. But that usually, if I just purely do a KBL, then for like 2-3 weeks, depending on how long they can maintain this, I think that's a safe period. Lying on your tummy and not lying on the fat while you sleep, I think that also helps, and most patients are very aware of that.
Are the results affected once they, like, let's say, sleep on the side?
Well, okay, so it's theoretically yes, and I would say that knowing the physiology of fat grafting, less pressure is better. However, I do tummy tucks and butt lifts at the same time.
Yeah.
So what do these patients do? They lie on their back, because you have to lie in this kind of jackknife position for a few days in order to allow the tummy tuck to heal. While now suddenly they say, "Doc, but now I'm sitting on my sleeping on my fat in my buttocks. All of that will go away." But then, after 5 years of having done this on a regular basis, either breast augmentation, breast lift, breast reduction plus butt lift, tummy tuck plus butt lift, any combination where patients were sitting on the buttocks, the outcome is still fantastic.
Okay.
So if you just do a butt lift alone, avoid sitting on it. But if you do the combination, it still works, and that's why I do it. So rather than throwing the fat away, I tell them this is stage one. So stage one is, instead of throwing the fat away, we fill your hip dips And if you look at my before and after pictures, it's just fantastic how you can see, even after stage 1, it is a transformation. And then if my patients say, listen, now I'm really happy with this, but now the buttock needs to be a bit rounder, then we do stage 2, and that then I would look at not putting too much pressure on.
Oh, and moving on, I think you're about to close. What's the one uncomfortable truth that exists when it comes to doing these procedures?
The one uncomfortable truth?
Yeah.
There's so many. I think we talked about the high risk. I think that's number 1. And choosing your surgeon who can safely perform it. Number 2 is the expectations, maybe. You're welcome to come to see me and bring pictures from Instagram.
Yeah.
But I will most likely tell you that genetically, maybe that person is different. Maybe they used Photoshop. Maybe they had several surgeries. So it's up to me then to tell patients, okay, this is what I can do. I have many, many, many thousands of before and after pictures that I show them. And I say, this is similar to what you have at the moment. This is what we were able to achieve in 1 operation or in 2 operations. And then kind of managing those expectations usually gives me a good feeling that the patient understands. And also the patient then appreciates that I'm honest. And I tell them, this is what I can do and this is what is safe. But if we do stage 2, maybe stage 3, then we can really get to where you want to be.
Wow. And there's one thing that's been asked frequently on social media. Is there a BBL smell or a KBL smell?
Hey, I've never heard of that. You know that?
Serious?
Yeah.
And where does it come from, though? Because on socials, it's almost everyone talks about it.
I had to look it up myself, to be honest. And so what I understand what the BBL smell is, because we don't have the KBL smell.
Nice one.
So I think from a medical point of view, most likely it's related to high volume lipofilling. So high volume where I don't know. This goes back to the early years of Del Vecchio, putting in 1 liter, 1.5 liters, and even more cc into each buttocks. That was the time when people put fat into the muscles, etc. So we've moved away from that. My average amount of fat nowadays is between 300 and 400 cc each side. So that's much less than what the Americans do, but it's much safer. So high volume BBL might influence certain aspects in the recovery. For instance, if the patient is a bit immobile, so they can't keep the hygiene very well. For instance, the hygiene going to the toilet, then maybe also there's more oozing of fat. And if they don't change the dressings or if they don't change the garment regularly, then you get bacterial colonization of not only the skin, but also the garment. So hygiene, bacterial colonization, I think maybe infection, but that's very rare and that would be a serious complication.
Thing,
and so the smell will not be the main issue there. So having said that, I think you can avoid it by adhering to safe surgery and good aftercare, regular hygiene, and
nutrition as well.
Nutrition, I guess, as well. Yeah. So keeping it healthy.
Is there a way we can have a procedure done that looks natural? What's the process? Is it purely technique, or there's a number of factors that also come in?
You need to define natural. What is natural in Kenya might be different in Europe, different in South America. So from my point of view, I think the feminine figure of a good ratio of your chest size versus your waist size versus your buttock size, where it is in balance, maybe the balanced look is what you're looking for. That is what most of my patients look for. You have some who then look at the social influencers who have exaggerated buttocks, and some people have it naturally, and that's fine. That's totally beautiful. And but if you are a very slim person and you want to look like that, then I would it would be my responsibility to tell you as a doctor that this is just not possible, and probably also not safe. So it depends on really what the patient wishes to achieve. Most of my patients are looking for the balanced look and the silhouette, the S-curve, the kind of feminine
and
figure.
Lastly, we're just about to close. When do you think the operating surgeon should stop and say, no, we can't do this?
Well, first of all, you're probably asking beforehand. So before you start operating, so during the consultation, then I would say if the patient's not fit and healthy, if the expectations are not aligned with what I tell you as a doctor, what is safe and achievable. So those are some red flags, that are there. Generally in plastic surgery, they're always red flags. But that is up to the surgeon then to decide that what you're coming in for in your state. So either you're morbidly obese, you're not healthy, you're smoking. The most important thing is, I don't want any complications. I don't want the patient to be disappointed, because disappointment is also a complication.
True. Oh, wow. I think we've come to the end of it. This was an interesting podcast. Thank you, Dr. for coming through. I've been looking forward to having you for a while. Thank you for honoring us. We've come to the end of it. If you guys have more questions on any plastics procedure, or any cosmetic procedure, or any reconstructive procedure, we have one of the best specialists internationally and within the country, so you can always reach out to him. We're going to share his contact info and the website, so you can also go through his pages. The name is Dr. Tillman Stash. This is the Laughing Lab Coat. Dr. Mahideen, peace out.
Thanks for having me.
Thank you, Doc.
Nice.